अस्सलाम वालेकुम। आज हम स्टार्ट करेंगे फिर नॉन कॉमिटेंट स्क्विंट। सारे आ गए हैं मेरे हिसाब से, तो फिर स्टार्ट करते हैं। तो लास्ट टाइम हमने देखा था कि how a patient with tropias presents and we did all of the management, how a patient with phorias presents and we did all of the management. The last type of squint is non-comitant squint. So what is non-comitant squint?
The misalignment of the eyes don't stay same in all directions of gaze.
Bilkul. So the eyes are misaligned, that is squint. And non-comitant means that the deviation is not the same in all directions of gaze. So we will see how it's different in different direction of gazes. So when we discuss non-comitant squint, what are the different symptoms with which a patient or a person can present?
Diplopia, main.
Diplopia, that's good. What else?
Deviation of eyes.
Deviation of eyes, squint, because there is a squint. Yes, there is a deviation of eyes. Deviation of eyes. What else?
Restriction of ocular movements.
Yes, restriction of ocular movement. If the non-comitant squint is a restrictive type. What else can be the symptoms of non-comitant squint? सही symptoms होते हैं, कोई और नहीं होता इसके अंदर. Can a head tilt be present?
Head position.
Yes, the person can have pain, especially if it's due to an inflammatory cause, that restrictive squint.
Vertigo.
Vertigo, yes, because we know that in physiology we have studied that in order to maintain position and upright posture, the eyes and the ears, they are necessary along with the proprioceptors in our body. So if we remove one of those, or one of those is giving us different stimulus than the ears, then the vestibular system, and the proprioceptors in our body, then yes, he will have vertigo. Patient will have vertigo. What else? Related to vertigo, the patient can have
Nausea.
nausea. Yes,
Nausea.
patient can have nausea. Now, if I write headache along with pain, so what do symptoms number 5, 6, and 7 they point towards? 5, 6, and 7 specifically.
Diplopia.
No. 5, 6. If there is a person with symptoms number 5, 6, and 7 only, what will you think? What should come into your mind immediately?
Something related to या तो cerebellum या inner ear.
Bilkul. CNS.
Balance.
Headache, vertigo, nausea. So yes, there's something related to the CNS and the cerebellum. It should come. What should come into your mind is raised ICP. Because these vertigo, nausea, and along with vomiting, these are the symptoms of raised intracranial pressure, and raised ICP can cause lesions in the nerves, in the cranial nerves, which innervate the extra. Now, one more symptom before we move on to our case. One more symptom. So there's diplopia, there's deviation of eyes, there's restriction of ocular movement, head tilt, pain or headache, vertigo, nausea, and vomiting. What else can be there? Okay, so another symptom is called false projection. False projection, does anybody have an idea what false projection is?
Pointing the finger in wrong direction.
More or less this pointing finger. Let's suppose that we have two objects placed in front of us. ठीक है, आपके हाथ में phone है, behind that phone is a laptop screen or any other screen or any other object. If you close one eye, you will know, आपको हाथों से भी पता है because one thing you're holding in your hand that the phone is closer than the laptop screen. But similarly, if two objects are placed and and you're not touching them, and if you reach for one object and you find out that you've overreached or underreached, यानी कि आपको समझ नहीं आ रहा कि वो कितना दूर है, या राइट साइड पे है, लेफ्ट साइड पे है, और आपके हिसाब से जिधर होना चाहिए वहां पे हाथ रखते हैं और आपके हाथ में नहीं आता, that means that the object is not where you perceived it was with using your eyes. So that is called false projection. ठीक है,
जैसे हमने cerebellum में पढ़ा था ना, overshoot, undershoot.
Overshooting.
yes, overshoot and undershoot जो cerebellum में होता है, that is past pointing. मतलब the concept is similar लेकिन that is different. Why? Because the person knows where that thing is, ठीक है, but due to inability to coordinate his muscles, he undershoots or overshoots. In false projection, the person does not know where the object is because his reception, his input, the stimuli in his sensory organ, the retina, it's not on the right place. Okay? That is not being perceived rightly by the brain, and that is why there is an undershooting and an overshooting or inability to locate the object accurately. Whereas in a cerebellar disease, the object is located accurately. However, due to uncoordination or incoordination of the muscles, the person is not able to grasp that object. So yes, the idea is similar. However, the cause is different. So these are more or less all of the symptoms which we will find or which we can find in a person with non-competent skill. So let's start with our first case, which is this. What are the symptoms in this case?
Headache and doubling of vision, diplopia.
Headache, one, and doubling of vision. We have two important. Now, the headache, we know that there can be a lot of causes of headache. So, and doubling of vision, there can also be a lot of causes of doubling of vision. So, how will you work up and manage this? How will you evaluate this patient?
सबसे पहले तो देखेंगे कि मिसअलाइनमेंट नजर आ रही है या नहीं आ रही है.
सबसे पहले यही देखेंगे, इससे पहले कुछ और भी करेंगे.
Visual acuity करें.
Visual acuity, yes. We will always do the visual acuity first. Okay, and we will also check his
Cycloplegic.
Cycloplegic refraction.
Cycloplegic refraction. Yes, cycloplegic refraction. इसके बाद हम क्या करेंगे? We've done his visual acuity. We find out that his visual acuity is normal. Let's say 6. It's 6 by 6, right? He has good vision. What do we do next?
Endoscopy.
We perform an ophthalmoscopic ophthalmologic exam, which includes the fundoscopy. Get the fundoscopy, and the fundoscopy is mostly unremarkable, except for papilledema. What next?
Eye movements.
Eye movements. Eye movements. You do the eye movements of this patient, and there's nothing wrong in some positions of gaze. However, when you do the horizontal movements, this is what you see. Based on this figure, एक second. Based on this figure, which muscle do you think is affected?
Right lateral rectus.
Right lateral rectus. Why do you think that the right lateral rectus?
Like B में left eye is seeing this way, but the right eye is not seeing.
Bilkul. So we can see that when the gaze is centered, there is no deviation, and towards left conjugate gaze, this child is looking towards the left. Both the eyes are looking towards left. However, when the person is looking towards right, only this left eye is acting, meaning that the lateral rectus of this eye is not. All right. So on eye movements, we see that left conjugate gaze is affected. And you have a suspicion that right lateral rectus. Right conjugate gaze, right? Because this is the right side of the patient. So right conjugate gaze is affected, and we suspect a right lateral rectus dysfunction. So how will you further work up or manage this patient? अब आगे क्या करेंगे?
Perimetry.
Perimetry हम क्यों करेंगे?
इसका फील्ड चेक करने के लिए.
Field of vision से हम क्या देखना चाहते हैं इसके perimetry? What are we looking for specifically?
कहाँ पे इसको विजन खराब होता है इसका? किस फील्ड में?
Vision किस फील्ड में खराब होता है? Right. So the important thing is perimetry. Why we do perimetry is क्योंकि हमने eye movements पे देखा that the gaze is affected, right? And we know that in non-comitant squint and there is diplopia, we know that both the eyes are well, they have good visual acuity, so they have the ability to fixate on objects, and binocular vision must be present, which is disturbed acutely, right? So when we do perimetry in such patients, we do perimetry to assess the fixation field. Fixation field का क्या मतलब है? आपको perimetry का पता है कि using perimetry, the peripheral field is measured in binocular vision कि कहाँ तक extent है बंदा देख सकता है. However, if you remember, if हम perimetry करते हैं, we ask the person or the patient to look straight ahead or fix at one point, और फिर हम उसका peripheral vision check करते हैं. ऐसे ही ठीक है. लेकिन जब हम fixation field check करते हैं, इसमें हम patient को ये नहीं कहते कि you have to fix at one point in front. हम patient से कहते हैं you have to fix on that stimulus which is being given by the perimeter. उससे ये होता है कि we find out that how much outside his normal vision or how much outside the center point can this patient fix on an object. That is called his fixation field, which we find using perimetry. और fixation field find करने का मकसद क्या होता है? Right? इससे हमें
ये सेस हो जाएगा. हाँ.
बताओ
कि मतलब इट्स नॉट लाइक कि वो उस तरफ से ब्लाइंड तो नहीं है जिस वजह से वो आंख वहां मूव नहीं कर रहा है.
बिल्कुल that is correct. एक वो चीज हमें पता लग जाए कि secondly we will have a confirmation कि किस तरफ किस केस में जाता है fixation double fixation. So the perimetry, it confirms our suspicions and our clinical examination that right he has his right conjugate gaze is affected, and the problem is only in his right conjugate gaze. When he fixes towards his right, he sees double. There is diplopia present when he fixes towards the right. Now, what else can we do?
मतलब कि राइट साइड उसकी फिक्सेशन फील्ड से बाहर है ना?
नहीं, बाहर नहीं है. देखो जब फिक्सेट करते हैं ना when there is binocular vision, तो both the eyes should fixate on one point. ठीक है? That moving object in the visual field in the perimeter, it should appear as one single point, right? If both the eye, there is fusion, there is binocular vision. However, if he sees double in that fixation field, It means that the left eye is not able to fix at that point where the right eye is fixing, or the left eye is able to fix at that point at which the right eye cannot fix, not fixate, not see that object. Okay? So it doesn't mean कि उस field से बाहर है, it means that there's a problem with the conjugate case on that side. So you find out this. Now, what else can you do?
Cover and cover.
Cover
Relative
and
movement.
cover. Cover and cover test. Yes. Why do we do the cover and cover test in non-common?
Relative movement.
Relative movement. Relative movement के बारे में क्या कहेंगे आप? What do you mean by relative movement? क्या पता लगेगा relative movement से? मतलब cover and cover tests relative movement of one eye, the squinting eye in respect to the fixing eye.
मतलब पोजीशन क्या
इनकॉन्कोमिटेंट
होगी?
रूल आउट हो जाएगा.
Committant और non-committant इसमें rule out
कॉन्कोमिटेंट रूल.
हम तो rule out कर चुके हैं ना eye movements पे. Eye movement we said that only the right conjugate gaze is affected and we had suspicion. So the cover and cover test in this case is done in all 9 positions of gaze. ठीक है, आपने extraocular muscles पढ़े थे, आपने positions of gaze पढ़ी हैं. First day session squint start करने से मैंने पहले आपको कहा था कि आपने पढ़ी है. So we perform the cover and cover test in all the 9 positions of gaze. Why do we do that? ठीक है, one thing is good. आपने बता दिया कि yes, we will find out that there is a committant and a non-committant squint. Meaning that either there is a tropia, or if a tropia is manifested, yes, we can find out that. Another reason for doing is
Relative movement कितना है जो आई जिसमें प्रॉब्लम है with the fixing eye?
yes, that relative movement is wrong. Now, उस relative movement को when we talk about non-committant squint, we discuss that relative movement as primary deviation and secondary deviation. क्या कॉन्सेप्ट है आप में से किसी को प्राइमरी और सेकेंडरी डेविएशन का? नहीं है, चलो हम इसको डिस्कस कर लेते हैं. Now this is very important. ये स्टेटमेंट आप मैं कहने लगा हूँ, you have to keep it in mind. This is very important. In concomitant squints, which are tropias, esotropias, exotropias, hypertropias, hypotropias, all of them, the primary deviation is equal to the secondary deviation. However, in non-concomitant squints, in restrictive squints, in paralytic squints, in kinetic squints, all the non-concomitant squints, the secondary deviation is greater. ठीक है, just remember this point at this moment. आपको ये याद रखना है. When we perform the cover and cover test, if the secondary deviation is very large, हमें cover and cover है पता लग जाती है. When we check all the 9 positions of gaze, this statement is very important. Primary deviation and secondary deviation. Primary deviation and secondary deviation are equal. Primary deviation and secondary deviation are equal in primary deviation and secondary deviation are equal in equal होता है. ठीक है, they are equal in concomitant squints. ठीक है, and they are unequal in or ST is greater than concomitant. हम redundancy कौन करेंगे, हम use करेंगे non-concomitant, right? You have to keep this point in mind. It's very important, this point. Deviations are equal in concomitant squints. They are not equal because the secondary deviation is greater in non-concomitant squint. ये चीजें क्या होती हैं, इसको हम उसके बाद. What else can we do? How will you further work up or manage this question?
MRI और CT करवा सकते हैं अगर कोई ट्यूमर या SOL चेक करने के लिए.
Exactly, we will do an MRI or a CT scan. क्यों करेंगे हम? हमें क्या इंडिकेशन मिली है अभी तक कि we need to perform this?
कि कोई SOL
एप्लोडीमा
हो
जो था,
सकता है.
हमें अभी तक एग्जामिनेशन पे जब हमने परफॉर्म किया इस पे हमें क्या इंडिकेशन मिली है?
फंडोस्कोपी पे जो पेप्लोडीमा मिला था हम उसके लिए
Yes,
करवा
exactly. बिल्कुल, उसके लिए हमें करवानी चाहिए. When we perform the CT scan and MRI, we perform an SOL, space occupying lesions in the subarachnoid space. ठीक है? The SA space or impeding space. Yes. What else can you do? ज़हन में कोई चीज आ जाए, anything. So there are two other important tests which we need to perform. One is Diplopia charting. Okay. What is Diplopia charting? The person is asked to look at an object or a chart using both eyes, and where he sees diplopia, it's measured or it's recorded, both by his examination, both by his perception subjectively, and both by the examiner's perception, which means it's recorded objectively. So let's say that this is a diplopia chart of the patient. This is the patient's right side in this picture. And this is the patient's right side in this picture. So this is what the patient is seeing when diplopia is being charted, and this is what you are seeing as an examiner. ऊपर पिक्चर है जो आप देख रहे हैं, नीचे पिक्चर है जो पेशेंट को नजर आ रहा है. You can see that in this
हम
chart
एज
there
एन
are.
एग्जामिनर कैसे देख सकते हैं? मतलब हमारी आइज में तो डिप्लोपिया नहीं है.
हमारी आइज में बिल्कुल डिप्लोपिया नहीं है. ये दरअसल इसकी मिरर इमेज इस तरह से कि दिस इज व्हाट द पेशेंट इज सीइंग एंड दिस इज व्हाट यू आर, मतलब जो आपको नजर आ रहा है व्हेन यू सिटिंग इन फ्रंट ऑफ द पेशेंट एंड यू मतलब आस्किंग हिम टू टेल वेयर द डिप्लोपिया इज एंड ऑल दैट. ये इससे मतलब इसमें इंक्लूड किया मैंने क्योंकि जो मूवमेंट्स होती है ना, आई मूवमेंट्स, व्हेन वी डू आई मूवमेंट्स, वी हम अपने हिसाब से देख रहे होते हैं, राइट? तो व्हेन वी से इस तरफ हमें पता है कि ऊपर कौन सी मूवमेंट हो रही है, इस तरफ ऊपर कौन सी मूवमेंट हो रही है.
ये हमारी मूवमेंट है, ये पेशेंट की ही
पेशेंट
है.
की मूवमेंट है, पेशेंट की है. दिस इज व्हाट द पेशेंट इज सेइंग, दिस इज व्हाट यू आर सेइंग. देखिए, पेशेंट की राइट आई ये देख रही है, लेफ्ट आई ये देख रही है, और आपको पेशेंट के सामने बैठे हुए इस तरह नजर आ रहा है स्क्रीन पे, या पेशेंट बता रहा है कि डिप्लोपिया इधर है, डिप्लोपिया इस तरफ ज्यादा है, इतना कम है.
मतलब हो तो ये सब्जेक्टिव ही क्या ना?
यस, एक तरह से सब्जेक्टिव हो गया, ये पेशेंट ही आपको बता रहा है. तो टाइम कम है, इसमें हम जल्दी फोकस करते हैं. सो इसको हम ले लेते हैं. बट द पेशेंट इज सेइंग दैट देयर आर 9 separate blocks in this chart. ठीक है, for the positions of gaze. 9 positions of gaze होती है ना, in each positions of gaze. So in each position of gaze, it is checked whether the person or patient has diplopia or not. So if this is the diplopia chart of this patient, what do you think the lesion is, or where do you think the lesion is, or generally what are the abnormal findings in this case?
राइट साइड पे डिप्लोपिया है उसको.
ठीक है, तो number 1, we can see that the diplopia is on the right side. There is binocular vision, and single vision on the left side, or most of the left side, right? ठीक है, इस line जो this line, on the right side of this line there's diplopia, and on the left side there's norm. What else? diplopia center में जाता है या peripheral पे जाता है?
पेरिफेरल पे.
Peripheral पे जाता है, right? So we can see that the diplopia is more in this box as compared to this box. Okay, what does this signify? What does this
किस
signify?
साइड पे देखते वक्त उसको पेशेंट को ज्यादा मसला होगा,
बिल्कुल
सेंट्रली सही होगा.
बिल्कुल साइड पे दिखना. Now always remember that diplopia is greatest in the direction of action of the paralyzed or the affected muscle. Meaning that जिस तरफ का muscle है affected, जो muscle का action है, जिस तरफ उसने काम करना है, that side will be affected the most. So we can see that there was no diplopia on the left horizontal gaze, right? There's no mild diplopia in the center. The diplopia increases on the right side. And we see that it's also affecting the superior gaze on the right side and the inferior gaze on the right side. And it's greatest when the person is looking towards the right with both his eyes. So on the basis of this diplopia chart, which muscle do you think is affected?
Lateral rectus.
Yes, the lateral rectus of this patient is affected. So you did the diplopia charting of this patient, and you found out this. Now the diplopia charting is a subjective method, right? हमने अभी start में बता दिया कि patient हमें बता रहा है इस तरह होगा and how. So there's another method to check the diplopia. There are other methods or other tests. मैं इनके नाम आपको बता देता हूँ. इनको हम बाद में डिस्कस कर लेंगे. You have to remember the names. बेशक आपको मेथड इतना नाम रहा है. It's Works 4 dot. 4 dots are present in two separate pictures, and the alignment of the dots relative to one another is checked. One other test is S. इसको भी हम बाद में डिस्कस करेंगे. So we performed all of these testing. Now, what on the basis of these 9 tests, your examinations and the symptoms, what do you think is diagnosis? What is your diagnosis?
Restrictive, incompetent.
Restrictive, incompetent, and non-competent squint. All right, we have one diagnosis. Anyone else with a diagnosis?
पैरालिटिक भी हो सकता है.
Paralytic भी हो सकता है. So what do you think? Is this paralytic or restrictive?
लेकिन SOL है.
Restrictive हुआ.
Restrictive
होगा ना. तो हमें लग जाए, but how can we be sure? Is there any way we can be sure if it's restrictive or paralytic?
yes.
कैसे? How can we know?
Force reduction test होता है.
Force reduction test क्या होता है?
सबसे पहले पेशेंट को लोकल एनेस्थीसिया देते हैं.
ठीक है.
फिर उसके बाद हम फोर्सेप्स से उसी मतलब जिस डायरेक्शन में रिस्ट्रिक्शन है उस डायरेक्शन में पुश करने की कोशिश करते हैं आई बॉल को. तो अगर वो हो जाती है तो इसका मतलब है कि आगे कोई SOL नहीं पड़ा हुआ, मतलब कि फिर पैरालिटिक स्क्विंट था.
बिल्कुल. तो होता है ये कि we anesthetize the cornea and the eye. Topical anesthesia देते हैं. Eye की forceps होते हैं very small micro forceps. Using those forceps, we grab the conjunctiva and we manually, हम अपने हाथों के जोर से conjunctiva को pull करते हैं और push करते हैं in different directions. If we can move the eye in different directions और हमें लगता है कि there's no restriction in movement or the movement is free, so that means that the force reduction test says that the squint is not restrictive in nature, it's paralytic. How will you differentiate between a paralytic and a restrictive squint?
Force reduction test.
Force reduction test, that is good. हमने force reduction test भी कर लिया जो आपको पहले याद नहीं है कराना. Now, what will be your diagnosis now?
अब पैरालिटिक निकला है.
Paralytic निकला है. आपने force reduction test कराया, you anesthetized the cornea, and this eye which was not moving in the right eye, when you use your forceps to pull it towards the right, it was pulled easily without any resistance.
इसका मतलब है कि जो SOL है वो नर्व्स पे इफेक्ट कर रहा है.
Nerves पे affect कर रहा है, ठीक है. That's pathophysiology. बिल्कुल ठीक है. तो diagnosis आपका क्या है?
Sixth nerve palsy.
Sixth nerve palsy. Why is there a sixth nerve palsy?
Because lateral
Lateral
lateral rectus को sixth.
Bill, the lateral rectus is being involved, and we know that the lateral rectus is supplied by the sixth nerve, the trochlear nerve. Okay, so our diagnosis is sixth nerve palsy due to
SOL.
an
compression.
SOL in the brain. Yes, we know that there are signs of increased intracranial pressure. When we did a CT scan, we found in an MRI, we found out that there's a space occupying lesion in the subarachnoid space, and that is causing an increased pressure. So that is most likely, most probably, impeding or impinging on the sixth nerve, which is causing the lateral rectus palsy. How will you treat this patient? How will you manage this patient?
Surgery, neurosurgery.
Neurosurgery. So what's the principle behind this neurosurgery?
To remove the SOL.
Lesion को remove करना.
I think we have to treat the
Decompression.
cause. Yes, we have to treat the cause. We have to perform neurosurgery. We have to turn him or forward him to the neurosurgeon so that he can remove that SOL and he can decrease that compression. That is right. We have to decompress. If there's an acute rise in intracranial pressure, we have to decompress. These are correct. The principle behind them is that we have to treat the cause. All right. So in this case, the treatment of the cause will most probably and most likely it will result in a proper reversal and proper correction. So what other methods? इस केस में सिर्फ यही काम करेगा because we know that there's an SOL. If we treat that SOL, we remove that SOL, things will go back to normal. Okay. So what other modalities in other kinds of non-combatant squints? What other modalities can we use? They can be used.
Squint surgery.
Squint surgery. Yes, we can use squint surgery in cases where nothing is helping or nothing is working and we have to strengthen the muscle or we have to relax one muscle. Yes, surgery can be done, especially in restrictive cases. And one other treatment is for diplopia. Why and how do we treat this diplopia? In अगले session में start करूँगा क्योंकि अभी ये session खत्म होने लगा है. So we will be back in around 5 minutes. All right?
Okay.
Okay.